pilon fracture. This model of a distal tibial joint, also a so-called pilon fracture, involves the talus and the ligaments. It shows the comminution of the distal tibia with impaction of a central joint fragment, which, after reduction, shows a large metaphyseal bone defect. In the first step, the oblique fibular fracture is reduced and stabilized. After reduction, we place a 5-hole 1/3 tubular plate to the lateral plane of the fibula and drive a lag screw through the center hole. We drill a 2.5 mm hole through both cortices, a 3.5 gliding hole close to the plate. Measure the depth. Cut the thread in the opposite cortex and insert the screw. All other screws are inserted as usual. This secures the fibula and determines the length for the reconstruction of the pilon. In a second phase, we expose the tibia with a longitudinal incision which begins lateral to the tibial crest, proximal, and curves slightly distally towards the medial malleolus. The tendon of the tibial anterior muscle and the dorsal vessels of the foot are raised and expose the lateral surface of the distal tibia. The medial fragment with the malleolus can be rotated outwards to provide a better view of the tibio-talar joint. The reduction of the tibial fragments begin anteriolaterally. This fragment is connected to the fibula via the anterior syndesmosis. Preliminary fixation with a Kirschner wire. To reduce the dorsal fragment, it is sufficient to slightly push the impacted central fragment aside. We will not remove it. Dorsal reduction is performed with a small sharp hook. In the following steps, we use the talus as an abutment. The fragment is fixed with an AP Kirschner wire. Then we reinsert the central fragment, again using the talus as an abutment. AP fixation with a Kirschner wire. Finally, we reduce the tibial malleolus fragment and also fix it with a Kirschner wire. This view shows the tibial joint section reconstructed on the talus and the central defect above it. We now plan final stabilization with the help of a buttress plate and screws. Instead of a massive frontal spoon plate, we prefer to use a cloverleaf plate, which matches the medial contour. This will prevent a varus deviation. Step by step, we replace the Kirschner wires by screws. In the shaft zone of the tibia, we use lag screws in the normal manner. When we tighten the lag screws, the fracture gap closes and thereby compresses the fragment to the tibial shaft. In the distal area, we use cancellous bone screws through the plate as well as to replace the Kirschner wires. Through the fixation of the plate, we simultaneously jam the previously impacted central fragment in its place. Finally, we fill the metaphyseal bone defect with previously extracted cancellous bone. place we inserted the preliminary K-wire into the central fragment is identical to the position planned for the screw insertion. Therefore, we will temporarily insert another wire and replace the first one by a cancellous bone screw. A washer prevents the screw head from sinking into the bone. The talus glides on a smooth joint surface. Now we insert the remaining plate screws. Distally, we plan to use cancellous screws with lag effect because they cross the fracture lines. In the proximal shaft area, however, cortical screws are inserted. Now we remove the Kirschner wires. The 4 operating steps may be recalled. First, fibular reconstruction with definition of length. Second, reduction of the tibial, especially the joint fragments, and stabilization with screws. Third, medial support by a buttress plate. And fourth, cancellous bone graft. The joint surface of the tibia is anatomically reconstructed.